Okay, let's get started. Let's do a time check. It's 2 p.m. in Singapore on Friday, October 29, 2021. On behalf of the Singh Health Duke-NUS Global Health Institute, I'm delighted to welcome all of you to this seminar today. I'm Amina Mahmood, Deputy Director of the Institute, and today the talk is part of our monthly Global Health Seminar series. In these sessions, we kind of draw from both our faculty as well as we have guest speakers to present topics of global importance and really engage with our community in Singapore and beyond. Today, we're especially delighted to have with us Assistant Professor Qian Long, who will present the results of an SDGHI-supported project. This project was awarded to Professor Shenglin Tang and his collaborators in Indonesia, as well as other co-investigators like Dr. Long. The project looks at integrating primary care co-management of TB and diabetes in Jakarta. So it's a really interesting hands-on implementation project. We're delighted to look at the results of today. Let me quickly introduce Dr. Long. She's an assistant professor of global health at Duke-Kunshan University. She has medical and international health training in China and the Netherlands. She completed her doctoral degree at the University of Helsinki in Finland and had postdoctoral training at Duke Global Health Institute, Duke University, as well as Duke Kunshan University. Her research interest and experience centers on health equity in relation to health systems development. She focuses on health financing and health services organization and delivery. She also looks at maternal and child health, tuberculosis control, and NCD diseases management in poor areas and among vulnerable groups in China and other low and middle income countries. Prior to joining Duke Kunshan University, she worked in the Department of Reproductive Health and Research at WHO, which is based in Geneva, for over 2 years. So Dr. Long, thank you so much for joining us today. We really look forward to the results of this study that you've been working on for a while. Before I hand over to you, a few housekeeping notes to everyone in the audience. Please keep yourselves on mute the whole time. This webinar is being recorded, and you'll be able to watch the recording of it after it's posted on our website. If you have any questions, please post them in the chat box at any time, and Dr. Long will address them at the end of the show. So over to you, Dr. Long, and thank you again for being with us.
Thanks so much. It's my pleasure to join the seminar today. Okay, so you can see this project is a joint effort. Then we had the partner from University of Indonesia. Then we also appreciate Sam Health, Duke, NUS give us the seat rights. So this also is kind of the pioneer to explore this kind of the joint adventure, and also we would like to expand the study skills based on this cooperation. So please, would you mind give to the next one? Okay, so when we're talking about this project, then some our students also ask the question, why are you concerned about the diabetes and the tuberculosis? One is a non-communicable disease, one is a communicable disease. But actually both of them share the chronic characteristics. Then there is a very clear evidence, the interaction between diabetes and tuberculosis. Then the evidence show for the tuberculosis patients are more likely to develop the diabetes. And also among the diabetes patients, we're 3.5 times more likely to get active TB. And also when the TB patients with diabetes, then they are also is more likely to develop multi-drug resistant TB. So that's also is kind of the global challenge right now. Then also TB with diabetes then has a highly mortality rate compared to the TB patients without diabetes. So that is some background. And also like the WHO and also International Union Against TB and Lung Diseases, then they produced a framework in 2011. Then they highly suggest to co-management tuberculosis and diabetes. So Indonesia is one of the highest TB burden country. And also we witnessed the rapid increase of prevalence of diabetes. So that's why Indonesia government in 2015, they have already started to think about, then they would like to design and also propose this TBDM co-management program. Then till 2017, then this national TBDM co-management program was implemented across Indonesia under the National TB Control Program. So why here I would like to highlight, even we call the TBDM co-management program, but actually when they launch this program, it's under National TB Control Program. So this also come to the later we can analyze some health system challenges. So based on this program, they have the three main components. Then firstly, they suggest conduct biodirectional screening of tuberculosis and diabetes at primary level. So that is one of the key components. Then secondly, continue the treatment and management of identified tuberculosis patients with diabetes, then without complications. So here, when they're talking about TBDM patients without complications, then they still suggest they can treat and manage this type of patients at primary level. Then if the patients with complications, then they need to refer to the higher level hospitals for the treatment. Next, please. Next, please, thanks. So for this study, sorry, would you mind just get back for the study objective of this study? Then according to this kind of the background, then we would like to examine the case detection and treatment outcomes of TBDM patients. Then we only do this study in Jakarta. Then we would like to identify what exactly what issued or documented in the policy papers, but also what exactly happened in real life settings. So that's why firstly, we would like to examine this case detection and treatment outcomes. Then secondly, we also identify the factors associated with the detection and treatment outcome of TBDM comorbidities. Then based on this kind of findings, we would like to identify key health system factors in order to develop evidence-based intervention for effective co-management of TB and DM in Indonesia. Next, please. Then in this study, we adopted a mixed method. Then, so firstly, we also visited Jakarta. Then we talked with a couple of stakeholders and visited primary healthcare center, Puskesmas. Then, so that also help us to understand what's the existed information or data source. Then how did they record this TB information, diabetes information, or other type of medical records? Then also help us to map what's the key stakeholders for the implementation of TB and DM co-management. So based on our this learning trip, so then we identified and also designed to use a 3 data source. And next, please. So firstly, we're also considering about some quantitative data. As said, this is kind of the pioneer study, so we don't do patient survey, but we think the TB register data also is very valuable data source to understand our study question. So we access to their TB register data. Then the time point is, because in the beginning we said in 2017, then under the National TB Control Program, then they launched TBDM co-management. So around 2017, they also update their TB register system. Then so we select East Jakarta and South Jakarta. So then we found by the end of 2017, East Jakarta has completed this update. So that's also is like include diabetes information in the TB register system. Then in South Jakarta, it's completed since the early of 2018. So that's our starting point to extract the data. Then till the end of 2019, so we had almost 2 years data to explore the change of detection and also treatment outcomes of TB and DM. Then we also do the qualitative interviews. So this kind of the stakeholder interviews, including the decision makers at the national level and the provincial level. Well, actually, we also talked with some regional level officer then to understand their perceptions and also their attitudes related to TB-DM co-management program implementation. Then we also talked with the first line tuberculosis professionals, TB doctors, TB nurse, who is responsible for registration. Then also some patients, identified TB-DM patients. So in addition to the first-hand data collection, then we also reviewed the documents, policy papers, including their guidelines for this TB-DM co-management program, then their implementation guidance, and also the so-called SOP in primary level. So that is kind of the practical guidance for the TB management. Yeah, next, please. So now we come to some key findings. Then we do some cascade analysis. So from this slide, you can see we firstly, from this TB register data, we have the total identified TB patients. Then we also analyze among these TB patients, how many of them took diabetes test. So then we found for two regions, both East and South, half of the new TB patients over 15 years old were screened for diabetes. So this also is our inclusion criteria for our study population. Then if we compare between East and South, so the East region for this screening is this performance for diabetes screening among new TB patients is better compared to the South Jakarta. Then among these patients who received diabetes screening, then we found 1/5 of them were diagnosed with diabetes. Then there also is a slightly difference between two regions. Then overall speaking, a vast majority of diagnosed TB-DM patients received standard anti-TB treatment. Then here I want to see a little bit is then we can only see in this TB register data, we can only see the treatment information for tuberculosis, but there is no information on diabetes treatment. So this also is one of the challenges we would like to draw from this pioneer study. Then I will explain a little bit more in the later. Among the patients who received treatment, then also like the 86% of those complete the treatment or get cured. So this also is kind of the outcome we identified from this TB registry data. The next, please. So that is like the overall situation that we compared. We found there's slightly difference between East Jakarta and South Jakarta. But if we observe the change over time, so like I said, the project, the program, the TB-DM co-management program launched in Indonesia, then that is in 2017. So if we compare between end of 2017 or early of 2018, then end of 2019, then we found this TB patients screened for diabetes increased from 41% in the early stage. then to the 60% in 2019. So this also shows, sorry. Oh, okay. So this also indicates with the implementation proceeding. So then this kind of the practice improved. So if we look at the treatment outcomes, like this also like said, is only for tuberculosis treatment outcomes. It's relatively stable across the years. But also as said, because this kind of the time period is relatively short. So we also need to follow up. And also if we have the longer years data, then probably we'll find some difference, or but we don't know. That's needed a further study. Next, please. So this also is in the regression model. Then we studied the factors associated with taking diabetes screening test among the TB patients. So like we said, the implementation period then shows significantly improve for the screening practice. And also East Jakarta did a relatively better job compared to the South Jakarta. But in addition to that, we also found the patient age, more than 45 years old, is also more likely to take the diabetes test. And patients with bacteriologically confirmed, then they are also more likely to take diabetes screening. Then interesting is, we found if this is a case reported by health center at sub-district level, actually also is more likely to take the diabetes screening compared to the hospital level. So then we would like to figure out what's the reason on that. So later I will explain some our qualitative findings. The next, please. The previous slide shows screening for diabetes among TB patients. Then this one shows the factors associated with TB treatment outcomes, including completing TB treatment and cured tuberculosis. So then we found the slightly difference. So it's only two with a significant, statistically significant difference. Then one also East Jakarta did a little bit better job. Then the patients who had the diabetes treatment, then also associated with a better TB treatment outcomes. Then here we also found, like I said, vast majority of patients received standard anti-TB treatment, but still has very few patients without standard TB treatment. Then we found among this one, largely is like the patients is diagnosed clinically without bacterial confirm. So this also indicates need to improve the case detection, and also probably we can use some new technology. Well, actually in Indonesia, they also introduced gene expert at the primary level. So that's also would be the way to improve this bacteria confirmed cases. Next, please. Then from our qualitative findings, then we also identified some challenges. Then also especially then what we do this kind of qualitative interview over the 2020. So during that year, then most of these health professionals, TB professionals, also talked about impact of COVID. Then they noticed it's a sharp decrease of TB case detection, and also free patients would like to come to the primary health center. Then focus on TBDM core management. Then the first we found challenge is about this health system governance. Like I said, this TBDM core management program is launched under a national TB program. So, and also in this country, TB showed a very high burden. So the country government also gives a high commitment and also attention on that. But now when we're talking about this TBDM co-management, actually we found there is no collaboration mechanism between TB and lung communicable disease program, even at the national level. So when we talked with the decision maker at the national level, then they just said, well, for our NCD program, we focus on manage or monitor or identify risk factors. Then I would like to take the preventive strategies addressing NCD challenge. But they don't really think about this kind of a relationship or interaction with TB. So when we talked with this decision maker, then it seems it's none of their business. Then, but for the TB, then they also thought, then, well, this is under my program, so we know this is important to co-management TB and NCD, diabetes. So then we also have already disseminated practical guidelines through the provincial regional office to the like the primary healthcare centers. So then, but what exactly happened in real life in the first like the primary level, they assume should be okay. So then when we interview the first line TB professionals, now we also found they have this kind of awareness. They aware there is this kind of the program. It's important, but still like the TB doctor do what they have to do. Then NCD doctor do what they have to do. So then, so largely for this kind of a screening, DM diabetes screening is only is a responsibility of TB unit, but it seems NCD units don't really involve a lot. So also, as said previously, for all this kind of information is only recorded, registered in the TB system, but not in NCD system. So that's why even they do the screening, but then during the treatment, TB DM patients during the treatment, now only have the anti-TB treatment information and outcomes recorded. Then for the diabetes treatment, then they said should be recorded in NCD units, but actually we didn't see this kind of the records. So that's, I think that is we identified one of the challenge in terms of the governance. There is no cooperation mechanism between these two programs. And also, secondly, we also identified insufficient promotion and dissemination of the co-management program. Why we see that? Like I said, even see by the end of 2017 or even the 2018, then this kind of the performance is still relatively, I mean, in terms of screening, is relatively low. Then we also found why it steadily increased in 2019. Then some TB professionals told us during like the second half of 2018, then there is regional office organized TB training. So that might be reason to contribute for the increase the awareness of TBDM co-management and also increase the screening. But also on the other hand, the NCD program, they have some like the very general risk factor screening program. So that is not for TB, so for all NCD risk factors. So then they have the very big scale population-based screening or surveillance program. So that's also might contribute to increase the screening of DM among TB patients. But overall speaking, this also connected to what else we found related to the health workforce challenges. So we think there is no sufficient promotion and dissemination of the co-management program. Then also finally, lack of incentives. So for these diagnosed TBDM patients, according to the guideline, the patients also need to take diabetes test monthly, and also return to the clinic to take the drugs properly. Then, but in reality, many patients didn't really take this monthly diabetes test. And also in this information system, we also cannot see this continued records. We only can see the screening for the diabetes when the patient's diagnosed at the TB at the first time. So overall speaking, then some health professionals also complain like the heavy workload, then they also cannot really follow up carefully. So that's also is kind of the governance challenge, no supervision, and also lack of incentive. But also, like I said, this also connects to other two types of challenges we identified. That next, please. So here, then we also talked about the health workforce. Then in both regions, then we found there is no targeted training for primary healthcare providers. Then TB health professionals, they do said, because they have this kind of shift, then when they come to the primary healthcare center, and also they are going to responsible for TB, then they will have some very general TB prevention, treatment, and management training. So that is kind of like the one-time training. There is no targeted training focused on TBDM co-management. So also, like I said, this program launched in 2017. Then, but after that, actually, there is no any specific training for this TBDM co-management. Then, on the other hand, for this training also, it's not like regularly they will refresh or they will update. It's only once time when they come to this clinic, then also start to work there. Then, so some doctors complain that there is no clear job description in TB unit. Then they just said, I did a lot of things, including the diagnosis, treatment, then also including some public health services like the outreach services, advocacy, and also community-based activities, then also some TB report. So they think they are overloaded. Then, but actually in some clinics, they also recognize this kind of the workload. Then they also assign like the one TB nurse is charge of reporting. But still, then they said there is like so many activities ongoing, including external audits, internal audits or supervision, then also other type of clinical activities. Then usually they will delay in the information report. So almost all the TB health professionals complain, CEO, they really suffer from heavy workload. Next, please. Then, so from the patient side, it seems there are also lack of patient-centered care. Then, like we said, in 2019, half of new patients screened for diabetes, but still half didn't. Then why many patients give up? Then one of the reasons is because of long queue and also inconvenience. Then that's many patients said, I have to wait there for a whole day, then get the diabetes test, but I cannot get the results immediately. then doctor asked me, you have to return to the clinic and pick up the report again. So that's why many patients just say, oh, it's I don't have enough time. I have many other like the have to work, other type of household work. So then they said, okay, I probably it's not so important for me. Then I just give up. So that's also related to the second finding, what we identified. Then the lack of this kind of knowledge and awareness. Then patients said, doctor is too busy, we don't have enough time to communicate, then they will give me the prescription, then I will go. So, but in the primary healthcare center, we do see this kind of the brochure and also poster in the wall, then showing this interaction between diabetes and tuberculosis and diabetes. But actually, patients didn't pay attention on that. On the other hand, doctor didn't have time to explain very carefully. So that's also cause this poor patient adherence, including this accept diabetes test, and also on the other hand is receive diabetes treatment or continued for this treatment. So this also is we found from our study. Then very few patients talked about this cost. Well, what we found is actually this kind of the services still covered by their national health insurance scheme. So if they accept the anti-TB treatment and also receive the diabetes treatment, is free at the primary level. But for some migrate, so it's like the patients not registered in this region, but they come to this primary healthcare center. If they get the diagnosis and treatment there, they cannot get the reimbursement. Then also other patients talked about this non-direct, non-medical cost. So that means this kind of the transportation fee and also like their accompanying members, then time consuming for their accompanying members. So that's also is some cost concern for the patients. But like I said, we don't do the survey, then we are not clear about their patient health thinking pathway. Then according to the health professionals, then they said, all the patients are free to choose where they want to go. But based on our data, like I said, this is TB register data and also our qualitative interviews, we cannot really identify their health thinking behavior. Then, but according to our quantitative analysis, we found the practice in sub-district health center is much better compared to the hospital level and also sub-district health center. So I think from the further study we would like to propose is to understand patient health thinking pathway, then that would be provide the more information and also contribute to the suggestion how to better organize or implement TBDM co-management program. Then secondly, also to understand this kind of the financial burden placed on the patients. The next please. Okay, so we come to the conclusion. Then as said, this is really like the pioneer stage. Then we found the introduction of TBDM co-management has improved diabetes case detection among TB patients in Jakarta, Indonesia. But for the implementation of this TBDM co-management program is suboptimal. So as we analyze this kind of challenges. So we would like to propose the policy dialogue and multi-sector cooperation be strengthened, then to improve the performance of co-management of tuberculosis and diabetes. Thank you.
Thanks a lot. That was great. Really nice to kind of get this overview. So let's see, and if we have some questions from the audience. I do know that we had one when they registered, so maybe that's the first question we'll go to. And the question was really about communicating the findings. How do you communicate your findings, and kind of how do you get suggestions with the government, with governors, and how what would the emphasis usually be to get a response from them?
Yeah, this is a really good question. And also it's usually like say when we do the policy research or health system research, then the first step, we would like to win the political support. Then like in our case, in the beginning, our Indonesia partner has already worked very closely with the Ministry of Health. Then firstly, inform them there is a kick off the project. We are interested about the TB-DM co-management program. Then we also would like to contribute like the evidence-based policy development or for the implementation. So that is really in the early stage of the project. Then we have already involved and also informed the decision maker at the national level, provision level, and also regional level. Then during the project, so then we postponed for a year because of COVID pandemic. So like I said, this really an impact. But even at this kind of a difficult situation, we still keep in touch with all these decision makers. Then get back to them what we have already done. Then we appreciate their support, access to the data. Then we also provide periodically feedback what our preliminary findings. Do you think this interpretation is correct? Or we had some misunderstanding, then we also have some personal communication. So that's why we do appreciate our Indonesia team. Then they did a lot of efforts. Then during this difficult time during 2020, then we often have this kind of the room meetings. Then they also schedule time with the decision maker, then also show them the progress of the project, then what's the key findings. So by the end, and the decision maker at the national level, they are very interested about our finding. But we also said our interpretation is really preliminary at the early stage because this is we only have the 2 district data and only for 2 years. Then if we want to have the more knowledge information, like we said, we're also interested about this pathway, like the health thinking behavior. Then we can know what type of patients come to the primary healthcare center, what type of patients go to the hospital. Then why at the hospital level, the performance is not so optimal than what happened there. So then we can provide more structure and systematic suggestion to support the implementation of TB and DM co-management. So I would like to say this is difficult, but we try our best then to engage the key stakeholders in our research process.
Yeah, and I guess for anyone kind of engaging with implementation work and implementation science, the end goal is always to have that impact on policy, but it is a long drawn out process. It's not something that happens very easily. But while we're waiting for questions from the audience, because I don't see any coming in at the moment, please do think of what you would like to ask Dr. Long, use this opportunity. But maybe I can ask a question about thinking about it kind of in an international context. Now, obviously, both TB and diabetes and, their coexistence is, a problem in just multiple countries all over the world, certainly Asia, but really all over the world. Can you maybe comment on other examples like this, or what's happening in other countries that could help inform what's happening in Indonesia and vice versa also?
Yeah, thanks a lot for the question. So we are also very interested. So then we did a very similar study in China. Then but we found really similar findings. What's happening in China and what happened in Indonesia. In China also, it's like the TB program pay a lot of attention on comorbidity of TB and diabetes. Because it seems for the TB person, then we're talking about who is expert for TB control, then they really have this kind of awareness and knowledge. See, this is we so-called the high-risk group of diabetes. Then they would more likely to develop anti-TB. But a similar situation in China is also it's a TB program pay more attention, but there is no like the regular communication between TB and NCD program. Then recently, I think it's around 2016. Well, actually, China also introduced the essential public health program in China launched around 2009. But since 2016, then they include tuberculosis case management into this kind of services package. So that also means under this package, the primary healthcare provider should manage both tuberculosis patients and diabetes patients. But in practice, there are also some complaints. Then like for the performance evaluation, they give the more weight to manage non-communicable diseases like the diabetes, hypertension, or other type of NCDs. But actually, that's also primary healthcare provider lose the incentive to manage tuberculosis patients. Then before, actually, when they supervise or monitor one TB cases, they can get fixed allowance from local CDC. But now, because they integrate into this kind of package, then they lost this kind of fixed allowance, but they get the less weight during the other performance evaluation. So that's why some primary healthcare provider also complain, say, well, actually, I manage TB cases carry on more risks compared to I manage NCD cases. But actually, it seems now for my performance evaluation, then they give them more weight to measure how I manage NCD cases. So that's also is what we found in real life setting also will help us to think how would be better to design the incentive or suggestions to improve the implementation. When we talk about this international recommendation, they issued in 2011, but till now, especially in low and middle income country or in no resource settings settings, there is very limited knowledge on the implementation on the core management of TB and DM. So that's why we thought this would be, we need further study. And also really it would be very important to do this kind of cross-country study than for the like the lessons learning or good practice learning and sharing.
Yeah, well, you bring up some very interesting points of not only what's happening at the country level, but maybe even looking at global funding. Because when you were talking about the kind of skewed incentives in China, well, very often in other low resource settings, I've heard it kind of the opposite way, where because of big organizations like the Global Fund and others who are funding TB, HIV, and malaria, and a lot of it gets concentrated on those three major diseases, whereas NCD cares in general and diabetes, specifically, doesn't get the international recognition and funding, and so you have vertical programs set up. So, what was your experience on that in Indonesia, and are there some ways to combat it?
So, do you mean this kind of the integrated model compared to vertical program, right?
Right, exactly. Because and based on a funding incentive, because why are those vertical programs there? Because you have a lot of global funders who are supporting that vertical program, right? So how do you
Yeah.
get away from that? Because I know when we worked in Cambodia, we tried to bring that around, but everyone is very proprietary about their vertical funded programs. So how do you break that cycle? But yet get the funding, you need the funding, but break the cycle of it being vertical and in a way isolated.
Yeah, I think this is a very interesting topic. Then in Indonesia, so why in the beginning we said, okay, we would like to take their advantage to use a primary healthcare approach. So it's not really like the vertically say only for TB control or vertically say for the NCD control, but that would be the integrated program or integrated efforts. But also, like you said, the funding agency, they are interested about maybe anti-TB control. So that's also bring a very important observation. Actually, for both TB and NCD control in Indonesia, they are also facing the funding insufficient. But compared to NCD, actually TB, they received global fund, they received the funds from other international organizations. The situation is better compared to NCD. So that's why they focus on the anti-TB control, tuberculosis control, then they also considering about this kind of comorbidity around the TB. But the NCD program, they said, well, then for our responsibility is doing some preventive strategies, identify the risk factors, then we don't have sufficient, they so-called energy. So I would like to assume that's including the workforce, then also including the funding for this type of activities. So that's why when we're talking about this kind of integrate, or we could see the joint efforts, then that's really need to multi-sector or maybe multi-level coordination, then integrate available sources, then also contribute to this kind of integrated activities.
Thanks for that. And I see a question coming in from the audience, which says, do you think lessons learned from the diabetes TB co-management can be applied to diabetes co-management of other chronic infectious diseases, such as Hep B?
I think so. So that's why for us, we study like the TB diabetes co-management, but what we analyzed is the health system challenges. So I would like to see some of this kind of the disease, like the services delivery organization, share some common challenges. So what's the example we identified the challenge for TBDM co-management, then probably also can apply for other type of co-management diseases. But also, of course, we need to do further situation analysis and see what's the difference between these two type of diseases management.
Right. So there are many different kind of applications of what you guys were studying. But, I mean, you talked a lot about the challenges, and obviously that's where, the focus should be, how can we overcome these? Did you see, some positive examples, which again can be shared, there's something that was happening right, and, look for those?
Yeah, well, talking about the good practice, then for sure, we think the step to launch co-management of TBDM program in Indonesia, this is a really big step. So they think this is very important. So that's why when we talked with the decision maker at a different level, almost all of them think this is important issue. But also, like I said, I think this is a very important point. If the decision makers think this is important, so then they would like to welcome the suggestions how to improve it. So that's why now I think Indonesia team also keep in touch with the decision maker at the national level for the TB control. So that's why they appreciate this kind of efforts. Then they also would like to see the further evidence. So then we said, we are happy to have some continued study or further study. Then, but based on the current project, we cannot answer all their questions.
Right. So we do hope that this project is, because that's for, as I mentioned in the introduction, this is an SDGHI supported project. And we do hope that these kind of initiatives are a launching pad to get further funding for, deeper and maybe longer term research on these subjects. But I'll kind of open up the floor for any other questions anyone has. Otherwise, not seeing anything, but it was great to have you with us so we can, kind of end a few minutes early. I think your presentation was so clear, but also, pointed out clearly some of the challenges that remain in front of us. So hopefully our audience was able to think about maybe how to not only overcome these challenges, but really how to kind of undertake these implementation studies that lead us in a policy direction, kind of going back to that first question. So Dr. Long, thank you so much for being with us today. It was great to have you. It was great to hear about the study. We'll certainly be looking to showcase this, as one of our SDGHI supported work. And we look forward to our continued collaboration with you and Dr. Tang, who's, the PI of the project. Thank you, everyone, the audience, for being with us, and look out for our next month's seminar, as always. And thank you for the team for putting it together.
Thank you.
Thank you.